Good evening, Endo Summit Live, and welcome to this edition all about bowel endometriosis. We are joined tonight by a multidisciplinary team. We are joined by a surgeon and a physical therapist. So I love that combination. Please welcome Dr. Bagaria and also Corey Hazama. Dr. Bagaria, can you introduce yourself?
Yeah, sure. Hi, everyone, and thank you, Sally, for having me here. I'm Dr. Madhu Bagaria. I'm an endometriosis excision surgeon. I trained at Mayo Clinic in Arizona. I love complex endometriosis cases, especially involving bowel and deep infiltrating endometriosis. And I'm very grateful to be here to share my insights. And I owe my patients because I learn a lot from them in their journey in the quest to learn to find answers for their questions. And my goal today is to make this presentation, this enigmatic disease, in a more understandable way for them and easier to navigate.
Excellent. And Corey, do you want to go ahead and introduce yourself?
Sure. Hi, I'm Corey Hazama. Sally, thank you again for having me tonight. I've been a pelvic floor physical therapist since 2015 when I started working at Beyond Basics. Now I'm a co-owner of our downtown location. Endometriosis cases have always been, a predominant patient diagnosis that we've been treating, and bowel related symptoms are very common. So I'm excited to be part of this panel.
Excellent. Okay, Dr. Bagaria, I think you have a presentation for us. Do you want to go ahead and try to share?
Of course, here we go. We share it. Um, can you guys all see my screen?
Yes.
All right. So I am currently based in New Jersey and I work with Endometriosis Surgical Specialty International. I have no disclosure to disclose. And today my goal is basically to understand bowel endometriosis just beyond anatomy. We know that the lesions, the symptoms of bowel endometriosis does not just pertain to the size and the depth of the lesion, but it goes beyond it. And there are other factors which can be playing an important role, which neuroinflammation is there, the immune factors comes into play, and there's so many things, the gut dysbiosis, and there's so many things which comes into play when we think about bowel endometriosis. And then we have to understand that disease diagnosis and treatment needs to be personalized because every patient's goal is different, and we have to take into account what their symptoms are and how the treatment aligned with their goals. And also understand why symptoms occur even when imaging or test results are normal. And this is a very, very common thing which we see. My goal is also to discuss a little bit about shaving, discord resection, segmental resection. These are very complicated terms, but I'm trying to simplify these terminology and will share some videos with you and what to expect after the surgery, because this is a very common thing. Yes, you had a surgery, but what happens next? Like, what do you expect? What's normal? What's abnormal when you have undergone through bowel surgeries? Going to the incidence, we know that endometriosis is very common. 10% of women of reproductive age, they can have endometriosis. And in that subset of population, people can have extrapelvic endometriosis. And in that, when we say extrapelvic endometriosis, it means that we know that endometriosis is endometrial-like tissue, which is outside the uterus and mostly in the pelvic side walls. And the most common location is the uterosacral ligaments, which is basically the ligament which goes from the back of the uterus to the sacrum. But when we talk about extrapelvic endometriosis, we have bowel, bladder, diaphragm, and among them, the bowel is the most common cause of extrapelvic endometriosis. And when we think of bowel, we have the small bowel, we have the appendix, and we have the large bowels. In that large bowel, we have the sigmoid and the rectum coming in, and it goes into the anal canal. And the rectum and sigmoid are the most common frequent site. And I'll show you a pictorial diagram where you see that the rectum and sigmoid are the most common site of endometriosis, about 70 to 90%. And then we have the appendix. We always talk about appendix and removal of the appendix with our patients. It affects endometriosis. In endometriosis patient, it can be affected in 3 to 18%, and they're often mistaken for appendicitis. And then the small bowel, it's very small percentage, but they can still cause significant bloat and constipation issues. So what are the common symptoms that is associated with bowel endometriosis? We are all very well aware that People can have pain with bowel movement, especially during the cycles, constipation, diarrhea, alternating bowel habits, bloat, the endobelly, which is very, very common symptom, which is caused, which most of my patients report, cramping, pelvic pain, rectal pressure, feeling of incomplete emptying. Another important thing is also they complain of painful intercourse, and there's a reason why they can have pain with intercourse, because most of these lesions are behind the uterus and the rectovaginal septum region where the lesions hide or where the lesions are. And these are the areas which get instigated during sexual intercourse. And that's why they can have pain with deep penetration. Most of these pains are deep, trusting pain. And pain can also happen, dysmenorrhea, nausea. Again, nausea is a thing which can happen in most of the cases because of the severe pain. The sympathetic system can get activated and can also occur as nausea. Nausea can also be a component of neuroinflammation and mast cell activation. These can also cause all these nausea and fatigue symptoms. And in rare cases, when the lesion is completely obstructing the bowel, these patients also run in the risk of having a bowel obstruction and going for emergency surgeries. And we know that these symptoms, they do not correlate always with cycles. Sometimes they can be cyclical, they can be acyclical, and the lesion can be in somewhere, it can be around the pelvic, but these people can still have symptoms because it is driven by inflammation and nerve sensitization. And they can have significant symptoms despite a normal imaging, despite a normal colonoscopy. So these are the things which are enigmas of this disease. Another very frustrating factor is the diagnosis is often delayed, and there are many factors which comes into play for this. We know that these people are complaining of constipation, diarrhea, bloat. These are the symptoms which can be present in people, normal people also who do not have endometriosis. In fact, one of the dietitians was telling me that bloating can be present in about 80% of normal population, and there's several reasons for it. So there's so many confounding factors which comes into play. And it has to be that endometriosis needs to be on our differential diagnosis. And most of the physicians, we live in our own silo and we don't think about endometriosis as causing some of these symptoms. And these symptoms can be cyclical, intermittent, non-specific symptoms. So when these symptoms occur, the first thing is like go to GI doctors. And some of them, they are not even familiar with this condition. And honestly, if beyond the GYN, I don't see many of the other specialties even talking to women about the menstrual cycle, about painful intercourse. All these things are not even discussed with women. So all these pieces of puzzles, they're not put together. And when they go for MRI and thinking about colonoscopies and all, we know that for the MRIs to detect, you need to have a structural disease. Even with the presence of structural disease in the MRI, you need to have trained eyes to locate this disease. And we know that some of these symptoms are driven by other factors, not just the structural disease. Talking about some of these people can have rectal bleeding, but when we talk about rectal bleeding, we often think about that there's a bowel lumen and there's a disease on the surface. To have rectal bleeding, we always used to think about, okay, the lesion has to be in the mucosa, or it has to penetrate through and has to be present in the mucosa. One thing which we don't realize that even if the lesion is not penetrating through and through the bowel mucosa, these people can still have rectal bleeding. And that can happen because when these endometriotic lesions are on the surface, they respond to estrogen. And when they respond to estrogen, they swell up, they bleed locally, and this can manifest in the form of bleeding. Second thing is that when there's inflammation, it can erode the vessels. So the mucosal vessels get eroded, and these vessels can present as bleeding, even though you do not have exactly a lesion on the mucosal surface. When we undergo colonoscopy, again, these can present as subtle fibrosis, things like that, but they're often missed because, again, the people who are doing the colonoscopy, they need to be aware of that these lesions exist. This happens also in normal laparoscopy when we undergo laparoscopic, like when they undergo laparoscopic evaluation, because again, you need trained eyes to be locating these lesions. So these can be missed because of ignorance and because we don't know how to spot this disease. This is a pictorial diagram about why colonoscopy and endoscopy can look normal in bowel endometriosis, because most of these lesions are external. And when we look at colonoscopy, we're mostly looking at inside the lumen of the bowel. So most of this disease, they can be interpreted as normal because the mucosa looks normal, or if they have subtle signs, we do not detect that these are actually a lesion there. So how do we diagnose bowel endometriosis? It's, as I said before, it's by putting the multiple pieces together, and it's not just by single test, which begins by listening to the patient's story, putting the pieces together, getting a detailed history about not only about the bowel movements or having a menstrual cycle, but getting a detail about even the bladder symptoms, because we know that when the nerves get involved, the bladder can also be having issues. A physical examination, in my opinion, is very necessary because then we can examine, we can do pelvic, we can do pain mapping, we can detect if there's any tenderness, nodules, and also by doing imaging studies, which includes an in-office pelvic ultrasound, which can be done if it is done by trained providers. And I'll discuss this further. It has a very good sensitivity, which means the probability of picking up the disease, and MRI as well when indicated. This is a study. I just wanted to discuss some studies because there's always a debate between ultrasound versus MRI in diagnosing rectosigmoid endometriosis. But there's several studies which shows that when you have a rectosigmoid, which is very low, again, sigmoid going to rectum and anal canal, so it is in close proximity to the uterus. And when we do a transvaginal ultrasound and you have the eyes to detect it, it has a very good sensitivity. In this study, they did a systematic review and meta-analysis of 8 different studies, and they had a population of about 1,100 patients who underwent both transvaginal and MRI. And these diseases were detected by histology, so they were confirmed after surgery by the pathology, and they found that transvaginal ultrasound had a very high sensitivity and specificity closer to MRI in detecting endometriosis. Again, if you look at it, we are using a probe. We are very close to the lesion, so we have a very good sensitivity in picking up these lesions in trained eyes. And how does the lesion look under ultrasound? So if you look around here, this is the cervix. This is the cervix. And we have to go low. Usually the uterus is here, and I'll show you a live scanning here. So this lesion appears as a hypoechoic lesion. So this is the bowel wall here, and there's a hypoechoic, which means it's more dark. It's more like fluid thing, so it's more dark in appearance, which looks like this. This is a very classic lesion when we look into ultrasound. So again, this is a mapping. So here you can see that we are scanning this patient. This is the cervix here, the cervical wall. And when it is doing, this is the lesion you can see very clearly. And sometimes we always talk about sliding sign. So when we talk about sliding sign, we are looking at how freely the bowel moves along with the movement of the cervix. We can see that this is fixed. It's not moving that well. And this is the classic lesion. It is measuring about 2 centimeters. And then just showing where we are looking exactly. So if you look around, this is the uterus, which is way here. Most of the ultrasonographers will look here, but they fail to look around the cervix where the lesion actually resides. Coming to the MRI again, we know that for rectosigmoid, which is the rectum and the sigmoid lesion, transvaginal ultrasound is very accurate, have equal sensitivity and specificity as compared to the MRI. MRI does have a role because sometimes when we do want to do disease mapping, which is beyond the rectosigmoid region, MRI is very good. It can also help us to know the length of the lesion, and the circumference involvement. All these skins can be measured by MRI. Also, when we're looking at lesion elsewhere, like in the uterosacral ligaments or in the bladder, in the ultrasound, there's usually a range like between 20 to 80%, which is kind of a huge gap, but MRI is more consistent. So again, in trained eyes, this gap can be further shortened, but MRI does have a role. But if you are trained in ultrasound can help you detect a lot of these things without undergoing through MRIs. Showing you the pictures in MRI, how does it work? So this is the classic mushroom-shaped lesions we talk about when we talk about bowel endometriosis. Again, this is the uterus here. This is a lesion here on the bowel wall. So again, similarly over here. And this one is I really like this picture because It's a very classic mushroom-shaped lesion, which we see on the MRI. So once we do the imaging and we see the patient in our clinic, the first important thing is like, how do we decide what is the right surgical technique? Should we shave? Should we do a disc excision, or should we do a bowel resection? Believe it or not, these are well guided. We have good guidelines as to when to recommend what, and it depends upon. So, but when we use this ultrasound or MRI, basic idea is to know what is the depth of bowel invasion. So if you look at the if you look at the bowel mucosa, you have different layers of the bowel wall. You have the serosal layer, which is this one, which is the most outermost layer. Then you have the muscular layer, which is circular and longitudinal. So there are two muscular layers. Then you have the submucosa and the mucosa. When we are looking at these imaging, we're looking at how deep the lesion is. Is this only on the surface, or is it going through and through to the mucosal layer? What is the size? We always measure the size of the lesion. Is it like 2 centimeters, 3 centimeters? This is important for us to know. What is the circumference of the bowel involvement? It is going like 50% of the bowel circumference is involving, or it is like 25%. And how far it is from the anal verge, that's also an important question, especially when it comes to colostomy and all those things. So it's very important for us to know all these things before we throw these recommendations on patients. And these are the specific guidelines as to if your lesions are small and if they're not narrowing the lumen and they're only on the surface, which is just on the serosal and the muscular layer, we can recommend shaving. But if the lesion is going further in, or they're compromising the bowel lumen, or they're more than 3 centimeters in size, then we go for segmental resection, which means we're removing a portion of the bowel and bringing it back together. But if the lesion is in between, then we can do a discoid excision. So this is a short video about showing about shaving. Here the nodule has been identified and lifted up. So you can see that we are, so this is a nodule which we identified, lifting it up, and by using electrosurgery, we are carefully shaving it from this is the rectal wall, we are carefully shaving it from the sigmoid region. So again, you have to be very mindful of your plane, making sure that you're removing the disease in the entirety, but without leaving any lesion, and you're just removing. And when we are doing it, when we are cutting it through the muscular layer, it does compromise the integrity of the muscular layer. So it needs to be further. So you can see there's a large defect here. So it is compromising the integrity. So we have to stitch or reinforce the muscular layer to restore the bowel integrity. And these patients can go home the same day, and they do very good. Again, this is a video I really like because this patient had multiple skip lesions and all of them were removed by shaving. It does show that how diligent you have to be in searching through all these segments of the bowel and removing them. When we look at this, I don't see any lesion, but there's something telling me that there is a lesion there. And when you lift it, you can actually see a lesion there. Like you can see now a nodule being formed here, which you excise first. Like how beautiful this nodule just comes to your surface when you kind of identify and lift it. Like I really like that. And then you're removing this fibrotic disease. Once we are done with this area of the segment, we move up a little bit and we identified another lesion here. So this is again being shaved off. Tiny lesion, but still there. Then we go up towards more higher up. So we are reaching now the sigmoid area. We identify another blue dot here, which we are going to excise. Again, a tiny one, still needing your attention. This lesion didn't look like endometriosis, but I was suspicious. And you can see it looks fibrotic. And if you look carefully, there will be a chocolate colored fluid coming, will be there. So this is a blue thing. And now you can see that there's a chocolate colored fluid. So this was clearly an endometriotic lesion, which could have easily been missed. So this explains why surgical expertise matter. Why do you need trained eyes? Because you could easily miss these lesions, which looks seemingly normal, but they're actually endometriotic lesions. So changing some gears, now we'll talk about disc resection for bowel endometriosis. So when we talk about disc resection, it's basically like you have a disease on the bowel segment, which is less than 3 centimeters in size, and it is less than 50% of the bowel circumference. So it is not going through and through the circumference of the bowel. So what you do is basically the idea is to use a stapler. So you go to the anal canal and you just fire that segment on the top surface of the bowel. So you're still removing a portion, but not through and through. So you do remove a lesion, a circular lesion around here, just on the front wall of the bowel, but not on the back. And then you stitch the two walls back together. This is less invasive as compared to segmental resection because you're not cutting a whole segment of the bowel. You're preserving the nerves, and it's less chances of having leaky gut or things or having any complications. So it's less morbid as compared to segmental resection. So as segmental resection means that the bowel is there, the disease portion, this whole complete portion is actually cut, removed, and the two segments are now brought back together in. So you're actually removing a portion in between the complete through and through. If you look at a pipe, it's basically a hose pipe. You're kind of cutting a portion of the hose pipe and then bringing the two ends together again. Again, as I said, it is actually removing a portion of the bowel wall, so it's a little bit more morbid, but in hands of good and experts, it's less chances of having complications. I also wanted to take a moment to talk about ileocecal endometriosis because in my 6 months, I have done 2 or 3 of these. I was involved in 2 or 3. And it does create a little surprise for the patients because they're not expecting, they're all thinking about an appendix endometriosis, but they don't think about that ileocecal region can also be involved and it can be a little bit more aggressive surgery. So this just shows an exploration of the thing of the bowel. So this is the large bowel here. And then here is a typical lesion when this is the cecum here and this is the small bowel. So this area, this one is the small bowel. And this is the area where you should be able to see the appendix, but this appendix is totally obliterated, which means it is totally engulfed in that lesion here. And the area beyond that, there's this large bowel. So in this patient, we have to resect a little portion of the small bowel, a little portion of the large bowel, and in that portion, you also have the appendix. When we take care of this, and then we have to bring the two pieces together. But when we are working with this kind of thing, we always worried about something which is called ileocecal valve. So what is that? So as the name suggests, it's a valve which goes from the ileum to the cecum. So from the small bowel to the large bowel. So it's a one-way valve. So what happens is that the intestinal contents, the small intestine content, when it goes into the large intestine, it cannot go back. And it also prevents the backflow. So the large intestine content cannot go back into the small intestine. And it also regulates stool consistency because it helps with slower transit and also helps maintain water absorption and everything. It also is very imperative for the gut microbiome because if the stool suddenly comes from the small intestine to the large intestine and it's kind of gush of stool because small intestine does have liquid stools. So it kind of disrupts the microbiome of the large intestine as well. So when it happens, these patients can suffer from diarrhea, which can be short-term or it can be long-term. But with diet and everything, it does get better. This is something I wanted to mention because I think this is important for people to know. We'll talk a little bit about recovery after bowel surgery. As you said, with bowel shaving, patients can go home the same day. But when we resect a portion of the bowel, either by disc resection or we connect the two pieces together by segmental resection, we do require patients to stay overnight, at least for a day or two. And this is not because some complication has happened. This is just a planned observation so that we can ensure that the bowel function has returned. Remember, whenever we do any bowel surgery, these patients also run in the risk of going into ileus, which is basically sleeping bowels, and it takes time for them to recover. But that phase of when the bowel is still kind of sleeping, can be very can cause nausea, can cause a lot of abdominal distension. So we want to make sure that these bowel function return back to normal before we discharge them home. So a little bit about what is normal, like after having a bowel surgery, especially like with shaving, we are okay. But when we do especially after the segmental resection, what is normal? Some people can have mild rectal bleeding during healing. It's because the sites of anastomosis, where the bowel pieces are connected together, they can have a little bit of bleed there, which you can observe as a little bit of bleeding during the bowel movements, and that's okay as long as it is not a lot. There can be some temporary bowel changes can happen like increased frequency, urgency, loose stools, diarrhea, and it takes about 3 to 6 months for these functions to become back to normal. There's something also called as lower anterior resection, which means when we resect a portion of bowel and bring them together. There's also something called low anterior resection syndrome, where people can have clustering of stooling. That means they're going to the bathroom frequently, they have fecal urgency. So these symptoms, they do resolve in about 3 to 6 months. As we mentioned, after ileocolic resection, diarrhea is very noticeable. And when we talk, especially when I counsel my patient about the diet after having a bowel surgeries, like soft, low fiber diet, this is because we think that we should take fiber in order to bulk the stools. But when you're bulking the stools, in my opinion, it also causes more bloat because the bowels are slow to wake up. It's not moving properly. So it causes more discomfort for them. Hydration is always recommended, gentle walking, and gradual return to normal foods. There are some people where symptoms can continue after surgery, and this can happen because, again, a lot of factors, because it is just not the structural disease or the lesion size or the lesion where it is located, but it's also a lot of other factors like the gut-brain axis, the gut motility, microbiome, all these plays an important role. And the gut microbiome, believe it or not, it takes about 3 or 6 months to recover completely. The immune system. We know that endometriosis patients usually have mast cell activation syndrome and have other underlying neuroinflammatory components, which we have not even named yet, which is undergoing. So these things can still be persisting, even though the inciting factor is taken away. But these factors, again, the immune system, working on the immune system and everything can take time. Diet and lifestyle. My pet peeve is like staying away from processed food. We know that certain food can trigger, so knowing those triggers and staying away from them as much as possible is always helpful. And again, understanding that nerves also play an important role. So trying to downregulate the sympathetic system and working with the parasympathetic system is very, very important. Again, that's all I have, and I'll take any questions.
Wow, that was quite the presentation. Excellent presentation. Wow, I'm a little speechless. So, before we move on, I have a couple questions for Corey, but before we move on to that, I have my own question. The ileocecal endometriosis, are we able to see that on any kind of imaging or only when you get the robot up close to the ileocecal valve?
Sometimes I have seen, like, look, when we do MRIs, we mostly do the pelvis. We never target the abdomen completely, right? So it is often, and sometimes if it is present, I've seen, like in one patient had a CT scan which was showing some kind of appendicitis-like features. Then it was present, but not usually because we never do abdominal MRI. And it's rare. It's also very rare, right? So, but when you see it, you can see that as appendiceal mass or things like that. It can come up.
Very interesting. Corey, we like that ileocecal valve, right? Do you want to tell everybody how you might work with that as a PT and why I found that part of the talk fascinating, actually?
Yeah, so like so one just from an anatomical standpoint, the ileocecal valve is very close to the psoas, and so as physical therapists, we're always very interested in the psoas. So again, things in close proximity to each other. Also, when things are being dysfunctional and who doesn't have a tight iliopsoas muscle, there's bound to be like a little irritability, but vice versa, if you have something going on with your ileocecal valve, not only could it like impact your musculoskeletal system, but then you're also going to see digestive issues. The as Dr. Bagaria was saying, the valves are supposed to be one way. And they're supposed to be, they're sphincters. They're muscular, skeletal, involuntary muscle, but they're supposed to stay shut until they're supposed to open. And so, again, when we think about like the pelvic floor, when we think about some of these other things, those are also sphincters. So there should be a good, like, muscular, kind of, reflexive contraction available in it. And so if this is disrupted by lesions or inflammation, then that could probably impact how well that valve is able to seal and close to prevent some of the backflow as well. So as physical therapists, some of us have training in visceral mobilization. And one of the things we do work on is the valves. And what we try to do is we try to bolster and increase some of that like energetic, reflexive reactivity to make sure that it's doing what it's supposed to be doing. So in other words, in my own physical therapy, musculoskeletal brain, I think about like increasing the tone, the reactivity, the strength maybe, but just so it can function how we want it to function.
There's a talk in the sort of functional health community that backflow you're discussing is a very big player in SIBO and CFO. Do you see that clinically?
I mean, it's so hard, right? It's like, chicken, egg, what happens? I mean, in theory, again, it's like, well, how are bacteria that aren't really supposed to be in the small intestine actually getting where they're supposed to get? And a lot of times with more of the methane producing ones, which is one of the harder ones to kind of get rid of, that tends to be very like deep in the bowel. So some of them, so it's closer to the ileocecal valve. Um, so again, it's like what happens first? It's like, does SIBO kind of set in because of certain, health or environmental factors or diet or whatever it is? Um, or is it like once it sets in, now that like affects how the ileocecal valve is functioning? There's probably a little bit of both.
Okay, excellent. So I'm wondering, Corey, this patient makes it to Dr. Bagaria, has excellent surgery, comes to you 3 weeks post-op. And what does rehab look like for a patient who has had a significant history of bowel and rectal pain and dysfunction? And I know that evaluation is like a case by case basis, but hit some of the basics.
Okay. I mean, first of all, I think, 3 weeks is like, wow, that's early. After such a major surgery. I
Okay.
actually probably wouldn't expect to see somebody that soon. If someone were coming in, obviously I would probably be staying pretty far away from any incisions or, doing any visceral mobilization because the things are still healing, especially with extensive surgery. So if this person came in at 3 weeks, my main focus would probably be on body mechanics, making sure they're removing well because we want to promote healing. We want to make sure that they're having good bowel movements. If that's, making sure their stool is staying soft, that they're getting enough fluid, that they know proper toileting postures, that they're not straining, and having some strategies, if they are struggling, how to, kind of how can they, best optimize and use their pelvic floor as efficiently as possible to make sure that they're having bowel movements without causing pain or additional strain. Whoops, you're muted.
Sorry, my mic was off. I was answering some of the questions. I want to remind people we really should be putting questions in the Q&A and not in the chat. So, what are some of those exercises that might attend to that central nervous system down regulation that Dr. Bagaria was talking about?
We're always going to mention the diaphragm. I mean, to some degree, as pelvic floor physical therapists, I'm like, are we more like breathing diaphragm specialists than we are pelvic floor specialists? I mean, in some ways, that's kind of like the go-to. We know that the diaphragm and respiration and breathing is one of the voluntary ways we have access into the parasympathetic nervous system and activating the vagal nerve to promote digestion and relaxation. So that's probably the go-to thing that we're focusing on is like, are you efficiently using your diaphragm? A lot of people get a little pushy. They hear like, oh, the abdomen's supposed to lift. And so a lot of people are actually forcing the abdominal extension with breathing. So making sure that they're really, utilizing the diaphragm in a manner that isn't putting strain on the abdomen or the pelvic floor.
Excellent. Okay, one more question, Corey.
Ah,
I have a question from our people this year could submit before they came to the webinar. And one of the questions was, how can you reduce abdominal cramping and painful bowel movements while you're waiting for surgery? Some people may not have
they,
heard of this thing that you have to
yeah,
be very good at.
this thing that we like, devoted our lives to, right? Um, So, I mean, again, it's like, it's hard not to have the bowel or the uterus or the vagina or the bladder impacted without having the pelvic floor being reactionary to that. So, in most of these cases, there is going to be a tight pelvic floor that is not fully able to relax. And so, pelvic floor physical therapy is really a good kind of first line. Entry point to start to address some of these restrictions that have been building up over many years to one, not only does it, optimize their um, recovery and their post-surgical outcomes, but also helps with some of the symptom management going forward. Again, we can't really change any of the lesions on the bowels, but certainly, the bowel is going through the pelvic floor and the pelvic floor is particularly tensioned. It's going to make those bowel movements much more painful.
Also, for those of you that attended last year's summit or are heading to this summit, and we talked so much about vagal tone with Ann Duke and how exercises to change vagal tone actually change the input to the bowel and the enteric nervous system. Even though you're not removing the disease, you can get the bowel to function very differently. Yeah. Okay. I got questions. You got answers, the two of you. I got questions. Dr. Bagaria, does bowel endo regrow and what is the rate of regrowth?
So bowel endometriosis, again, it depends upon, like if it depends on the phenotype of the disease. I will not say that every bowel endometriosis grow or, they will come back. It also depends on a number of factors. So I believe that the more aggressive disease it is, it can also regrow. The other important thing, in some things which have, like with shaving, you always have a propensity, sometimes, not all, I should not say always, but with shaving, sometimes you can leave the disease behind because you're doing a more conservative approach. So in that case, I feel like the bowel disease can come back. But again, the regrowth, if you look at the literature, is about 10 to 40%. So I always tell my patients that there's always 60% chance of not coming back. Don't look at 40% which comes back. There's 60% chance which does not come back. And it again depends upon how aggressive. If it's just a superficial disease, I don't think it should come. I mean, I should not say I don't think it should come back, but the likelihood of it is coming back is very, very low. But if you have a very deep nodule, very deeply invasive disease, then it does have, like depending upon how aggressive the treatment was as well.
So, I'm curious. We got a question from submitted beforehand. Do you think that Orlissa can help bowel disease or interacts with bowel disease in any way? And I don't remember the generic form of it. We do not work for that drug company.
Right. So again, it is just like any hormonal management, right? So when you give Orlissa, it puts a band-aid to your symptoms. It doesn't actually, so it helps with some of your symptoms, like when the lesions are not bleeding, then when the inflammation is calmed down. So you may not feel some of these symptoms because the hormones is kind of regulating it. It's regulating the regrowth of the lesion, the inflammation in the lesion. So you don't feel that excitation in the nerves and everything. But it's kind of a band-aid. It's not exactly a cure for the disease.
Excellent. Okay. Let's see. What percentage or what's the line of when lots of patients are told they can't have their bowel disease attended to because they'll end up with a colostomy? I mean, very rarely in my career, but what is the line that might have happen?
I will say that in my lifetime, I've seen two. So, so it's not that common. The thing when it happens, when it undergoes colostomy, you have to understand it's temporary because our goal, it's not a cancer surgery. Our goal is always to go back and revert it. Why do we give you colostomy during the time of surgery? There are two reasons for it. We have to, one thing is that we have to make sure that whenever we bring the two pieces of bowel together, we have to make sure it heals properly in our mind. Because if it doesn't heal, it causes you more issues. It can lead to bowel leak or fistulas. You end up in sepsis, which is a bad infection. And then you end up in a temporary, like a emergency colostomy, which is not a good thing for you, anybody, to undergo emergency surgery. So when we are doing the surgery during the time of surgery, we look at how far it is from the anal verge because it helps to determine the blood supply to the region, and that indirectly helps to determine how well the lesion will heal at that point of time. And second time when we give you colostomy is that when there's a lot of inflammation and we feel that the anastomosis will not heal at this point. So what we do is we divert your colostomy bag down there so that it heals, that lesion heals properly, the inflammation dies down, and then we go back and revert it back. So there are only two instances which, in my mind, when I think of giving a colostomy to a patient primarily, and that incidence is it's like close to it's very minimal. It's very minuscule. It doesn't happen all the time. The possibility is very low.
In my career, I've only had one colostomy patient, and it was reversed in 3 months.
Yeah.
And now I don't think it would be. It was very early on in my career. Now I think we're being
Yeah.
a little. We've changed our techniques a little bit. Corey, do you feel that exercises like yoga or other central nervous system experiences help the microbiome and help encourage like the way the bowel works?
I mean, that's a really tricky question. I mean, there's so many overlapping systems there. From a perspective of, is that bringing you, calming your central nervous system, and that like speaks to, your mind-body connection, and that's, works for you, then like, from that aspect, yes. But, can it actually, does that by itself promote, the improvement or the return of like, a better microbiome? I'm probably thinking that you're going to need a little extra support depending on how extensive the disease was or, how profound the endometriosis was, or if you have other overlapping conditions like mast cell or SIBO or hypermobility condition, like any of those things can further, I think, complicate, our gut microbiome.
Excellent. For our mast cell people out there, we have a video also up on our YouTube by Dr. Vidali talking about mast cell and the histamine response in the actual lesion of endometriosis that some of you may find very, very interesting. I'm curious, is it common to be put on a low residue diet after bowel resection? Not just low fiber and soft foods. What are the best foods to eat and to help heal post-op? Any good resources?
For me, when I think of diet after bowel surgery, I think of all the unhealthy foods, the foods you don't want to eat, like white bread, pasta, all the low fiber and all the foods which we generally tell you not to eat. And the main reason is because your bowels are slow. And obviously, after the surgery, you're not going to eat a lot. You won't, your appetite will not be to the extent like you were before the surgery, right? Your appetite does go down. And if eating this low fiber diet, it helps you're not bulking up your stools. And it's easier for your bowel to pass it through. So for me, I believe in low residue and low fiber diet. So low, and anything soft because it helps the easier it passes with the bowel, it's better for you until it heals and then once a bowel function returns, you can go back slowly in about 2 or 3 weeks. You can start adding more fiber to your diet, and you can resume the normal diet. So the restrictions is only for like 1 or 2 weeks until your bowel function returns.
Post bowel resection, I actually worked with an acupuncturist to help with my gut. And I was put on like twice a day. I had to drink these shots of aloe vera juice to help and also I think that was when I went through a slippery elm phase. And then everything was me who doesn't eat any rice because the glycemic issue, everything was like white bread and rice and all the things. I think I was eating cooked apples. We were like cooking apples in the slow cooker constantly. Yeah. But it's only a couple weeks afterwards. Yeah. So I'm curious, do either of you see a link between bowel endometriosis and celiac disease? It was a good question. We have lots of good questions tonight. So one of the other things, and I get this a lot, is that post-menopausal women often still have bowel pain, but their local doctor or OBGYN tells them that endometriosis can't persist post-menopausal. Any tips for how that person can access better bowel care or access better endometriosis care?
First of all, it's a myth that menopausal women cannot have endometriosis. We know that some of these women have never been diagnosed. Some of their pains have been lingering on and they continue postmenopausal as well. So if you are someone who thinks that your symptoms may be related to endometriosis, again, that it boils down to one thing, is advocating for yourself and finding the right specialist for yourself. I mean, it's sad that even women of the reproductive age group, when they're not menopausal, they also struggle to find the care. I mean, forget about the postmenopausal women because they are easily voodooed by the GYNs, right? Like by the physician saying that endometriosis does not exist in postmenopausal. So the best way is to just advocate for yourself. Find us online. Social media is a huge tool for educating people. I think it has become like one of the front line for education for like patients, unfortunately, or fortunately, I should say.
Corey, we got a great question for you. When you have pain with bowel movement, is it always endometriosis? Or what else could it be?
I feel like you're um no, I don't think if you're having painful bowel movements, you immediately jump to the conclusion that that you have endometriosis. Again, endometriosis has that diagnosis is made with a lot of testing and imaging and symptom analysis. It's not just because you present with like one single symptom. There's a lot of things around your rectum. I mean, it could be the pelvic floor, it could be your tailbone, it could be, maybe you even have like spasms in your external anal sphincter, or you can even have like hip pathology or tight hip muscles that are getting tensioned when you're trying to have a bowel movement, or because you're sitting on the toilet, and your hips are flexed and maybe you don't have the hip mobility. I mean, there's so many other components. If you are having pain with bowel movements, especially, something that just started out of the blue, I think it is a really good idea once you've been cleared medically to make sure that isn't something, a medical condition, to maybe see a physical therapist who can help to, kind of pinpoint, what maybe might be driving some of that pain and not just, jumping to the endometriosis diagnosis. Um,
We also want to tell everybody, all of our pooping pain people about the squatty potty a little bit. Do you want to explain what the not, you don't even need the trademarked one, but do you want to explain why positioning when you poop may be helpful?
Yeah, so there's this muscle called the puborectalis, and it slings around the back of the rectum and goes from the pubic bone. What it allows for us is that when we're standing, it allows our rectum to be in a little bit of a kink, so the poop doesn't fall out. So when we sit And if our legs are straight, it's like it's going to be a little, that muscle's going to be tensioned and you're going to have that little bit of a kink in the rectum. And so sometimes it makes it, poop doesn't really like to go uphill when it's coming out. So the designers of Squatty Potty figured out that if you flex the hips above, the knees above the hips when you're sitting, it helps to relax this specific muscle, and the poop's supposed to slide out a little bit easier. Back in our ancestors always squat to have babies, and they squat to have bowel movements. And if you've ever been to Asia and had to, squat over one of those holes in the ground toilets. This is how our ancestors always had bowel movements because they understood that like when you squat, it helps to relax the pelvic floor. Unfortunately, and this is some of the challenges that I've been seeing as a physical therapist, is that in our 20th century world, most of us have really, really tight hips. And so you throw a squatty potty at somebody and they can't even get their hip flexion to 90 degrees without their entire back flexing. The squatty potty isn't going to be like a miraculous fix. So again, seeing a physical therapist to help you with your hip mobility and your spinal mobility and your pelvic mobility, so that you can actually get into the position to relax your puborectalis in this position is actually really important.
Also, you don't have to spend the money on the squatty potty. You could use a step stool. We used to have these things called encyclopedias. Sometimes you could find
You're
like a
not going to
really
find
big,
one of those.
no, but there's a
Or a phone
menstruation
book. You're not going to
textbook
find
that's
one of
the
those.
size of that, but and sometimes you only need that for a little while. That's not, it's not something you're using every day. It's like until you reach the length in your muscles. Dr. Bagaria, a question about adhesions. Is there anything special to do to prevent adhesions in the bowel?
So as in any surgery, when we talk about adhesions, it depends upon the surgical technique. Hemostasis, which is basically having a bloodless feel as much as possible, not touching the tissues if it is not needed. And sometimes when we see a lot of inflammation going in, like when there's inflammation, these tissues bleed just on touching. We also use this adhesive barrier called AmnioFix. We started using in our surgeries. That also with the hope that it will prevent adhesions, because when there's a lot of inflammation, a lot of bleeding, like it kind of oozes, kind of you touch the tissue and it oozes. So that is sometimes we use it during the surgery, but most of the time it depends on your surgical techniques, hemostasis, and all those good surgical principles.
Very interesting. And once somebody's had a resection or had a shaving, and then 10 years go by and they have to have their routine colonoscopy, are there any changes that they have to let the GI doctor know of, or they're good to go?
They're good to go with shaving. With resection, you can just let them know because they'll be wondering why is your bowel so short, or it's like shorter than usual. And you can let them know that you had a segmental resection, but usually you're good to go.
Excellent. Okay, this was a wonderful evening on bowel endometriosis. We are going to talk a lot more about shaving versus resection at the Endo Summit. And then we're also going to talk a lot about anti-inflammatory lifestyle and encouraging your body to heal post-excision. And we also will have an enteric nervous system specialist from the Mayo Clinic who's going to give a talk all about the enteric nervous system and how the bowel interacts with the body. That should be really interesting. And that should be great. The Endo Summit is March 27th through the 29th, 2026. And it is coming up. We have limited availability in certain sessions. The lab for the physical therapist is almost sold out, just a few more seats in that. The party is almost sold out. We'll have to see if we're going to extend that. And the middle day is almost sold out. So if you're looking to buy in-person tickets to the Endometriosis Summit, you should do that, www.theendometriosissummit.com. Now, Dr. Bagaria, we end every Endo Summit Live talking about what are you looking forward to at the Endometriosis Summit?
For me, I think it's interesting to meet patients in the same platform, physical therapists, and it's a community. Also, it's not just surgical things you're learning. It's not just like research papers or things like that. I really like last time I really liked the art therapy thing which we had. Like these are very unique to Endo Summit. Those things I really like the non like it's a scientific congress, but we're also talking about like holistic way of taking care of patients. I really like that.
Actually, when Corey came, Corey did the first Endo Summit workshop. And they did this whole, do you remember? Because it's my screensaver. So I always see that little ball that you guys had. And they did this whole thing on self-mobilization of the sacrum. It was so interesting, right, Corey?
Yeah, that was a lot of fun. That was right before we went into lockdown.
I
So I'll
know.
never forget
The
it.
week before, the week before. So, patients are encouraged to attend the Endometriosis Summit. You can attend virtually. So you can attend from anywhere in the world. You can hear conversations that are much like this, but very in depth. Or you can attend in person in Orlando, Florida. And we are back next week. I have to check, but I also want to remind everybody that we will begin a second webinar every Monday night. So you'll get two webinars, one on these topics of endometriosis, but the other one for the fertility crowd. And we're going to do that with Emma, our embryologist, who was here last week, who promised us embryo night. But we're going to have the two separated so we can do lots of fertility information, but people who don't want it don't have to listen to it. And then we can do lots of endometriosis education. So thank you, everybody. I'm sorry for the technical issues. That's never happened in 8 years. We've got to figure it out. And we'll be back with you next week. Take care, everybody.
Bye. Thank you for having. Bye bye.
So amazing.